يا صباح الخير. اسمحوا لي باسمكم كلكم أهني اللجنة المنظمة على هذا المؤتمر العظيم الحقيقة. وهارت فيلير أنا بعتقد one of the new emerging epidemics. أنا بعتقد 4 emerging epidemics: heart failure, atrial fibrillation, degenerative disease of the valves, وmetabolic syndrome. first Jordanian Heart Summit راح يكون مؤتمر عظيم نتعلم منه الكثير خصوصا في الزوار والمحاضرين الكرام. First speaker of our conference today is Dr. Arvind Bhimaraj from Houston, Texas Methodist Hospital. I trained in Texas, and my daughter was born in Methodist. Aurora was born in Methodist, by the way. And he's the interim chief of Division of Heart Failure and the Becky Heart and Vascular Institute, and the medical director, Advanced Heart Failure, Mechanical Circulatory Support, and Heart Transplant Program. Please, Dr. Arvind Bhimaraj, please.
Thank you very much. Thank you for the invitation, and I want to congratulate the organizers, and especially Dr. Tabalat and Dr. Bader for inviting me here and really putting this, for the lack of a better word, battle against heart failure. And to win a battle, you first need to know how to identify your enemy. And so my task today is to talk a little about diagnosing heart failure. Many here, and probably most, are seasoned practicing physicians whose experience goes beyond my experience. So I'm going to keep it focused on a few things which we as heart failure specialists try to focus on the basics. I've also have a few basic slides because I was told that there might be trainees, students also in the crowd. One of the challenges with heart failure is it's a very vague term. And I tell my patients sometimes it's actually a very generic term. All it means is your heart's failing. An attempt to define heart failure has been made in the context of calling it a syndrome with a myocardial muscle dysfunction, because you can't call somebody who's in heart failure if you're having a mitral stenosis which can be fixed because their myocardium is not dysfunctional. You should either have LV dilation or hypertrophy, and of course that initiates the cascade of neurohormonal and circulatory abnormalities. If you keep this definition, it tells us that it's a clinical definition. It's a clinical syndrome. You diagnose it technically bedside with probably some diagnostics. But when we're trying to diagnose heart failure, it's not just about saying a patient has heart failure or not, but you want to go beyond and ask yourselves the question, is it heart disease with some other problem, like you're on dialysis and your volume overloaded? And the next question is, what kind of heart failure is it? Is it reduced ejection fraction? Is it left-sided? Is it right-sided? Dilated, hypertrophic? We have made this term confusing just by the history of medicine, and it's incumbent upon us to make sure these terms don't confuse us while we're thinking about a patient. And what's causing the heart failure, and of course, what are the comorbidities that are affecting it? And I highlight here that history and physical exam, as basic as it is your crux for heart failure, is your crux for diagnosing heart failure. And I'm sure all of you, I believe, outside the Western world, history and physical is ingrained as a crux of medicine. And that is a tool, a strength for heart failure in my mind. And when you're evaluating these patients, you move on to some investigations looking at cardiac structure and function, of course, the etiology of heart failure, with a particular attention to reversible causes. It's actually amazing if you sit and think about it, that 50% of coronary disease, at least in the US, is ischemic cardiomyopathy, which is coronary disease. But on the other hand, 50% is non-ischemic cardiomyopathy. It's a mixed bag. And when it's a mixed bag, you want to make all efforts to find what is reversible, because there's a big chunk which I have no idea why it's happening. We make up viral hypotheses, we make up genetic diseases which are not reversible, but you want to make sure that you diagnose reversible causes as simple as thyroid dysfunctions, anemia, and other factors. And coronary disease and ischemia is important to diagnose, and of course, identifying exacerbating factors, comorbidities, and barriers to adherence are extremely important while you're diagnosing these individuals, because your success depends on sticking to the medical regimen. Most of you should have seen these steps and stairways to stages of heart failure. It'll depend on which stage you're catching this patient for diagnosis, because if you're catching them up here where there's structural dysfunction but no symptoms, it's technically not heart failure, but it's cardiomyopathy. You could be seeing a patient in your clinic with no symptoms but got an echocardiogram for some other reason and has cardiac dysfunction. So you have to keep in mind, if they're asymptomatic, that your vigilance will be different. The clinical presentation that the patient comes to you is also important to keep in mind. If you have a worsening, majority of the patients come with symptoms, so it's relatively easy. 20% of them is de novo, which is the first-time diagnosis when you end up seeing these patients, and 5% are in advanced stage. But the profiles of presentation will vary, and that's why in each scenario, your diagnostic guard or the threshold of suspicion will change. If somebody is in hypertensive acute heart failure stage and gasping for air, you probably will suspect heart failure more so than in individuals who are in like right heart failure or in acute coronary syndrome or asymptomatic with vague symptoms. When you're thinking about heart failure, you also need to know the categories of heart failure, because it depends on what your diagnostic algorithm will be. And I like this classification, which is relatively new in the scheme of the diagnosis of heart failure, but your rejection fraction, and I'm sure all the cardiology folks will agree, as crude as a measure it is, defines on how you treat these patients. So if your rejection fraction is greater than 50%, it's called as heart failure with preserved ejection fraction. Your diagnostic algorithm is completely different. So you have to keep in mind that until you have an ejection fraction, they're just a clinical syndrome of heart failure. The one diagnosis I'm going to bring up just to, I don't know if we'll talk about this as the day goes by, is HFpEF improved, which means that the ejection fraction has improved today, but it was bad before. And that's a very important category in my mind, because these are patients you do not want to withdraw medications. And I like the fact that they captured this that definition here. But if you look at reduced ejection fraction, preserved ejection fraction, I don't know if my arrow is showing up over there, probably not. Okay. So if you look at the reduced ejection fraction, the mid-range, and then the preserved ejection fraction, you want to notice that all of them have symptoms and signs which probably will be similar. So all you can say is somebody has clinical diagnosis of heart failure, and then you have to come up with an assessment of a ejection fraction. Most of the times it's a echocardiogram that's commonly used. You can use other testings as natriuretic peptides most commonly to confirm the suspicion. But if you go back to the pathophysiology of congestive heart failure, majority of our discussion lies with left-sided heart failure. I'm not covering too much about right-sided heart failure, but that's a whole nother discussion to keep in mind, that if you're having right-sided heart failure, the pathophysiology completely changes. But believing the probability that all of us will see left-sided heart failure more, it starts with the fact on the left side of your screen that you will see the left heart failure leading to increased LV end diastolic pressure that leads to increased left atrial pressure that then transmits back into the pulmonary arteries, and that's when you get the congestion symptoms that we talk about, pulmonary congestion. I want to warn all of you that pulmonary symptoms can be masqueraded for a long time, and the pressures can be high, which is called as hemodynamic heart failure or hemodynamic congestion. And I'm sure if you do this enough, you'll see patients who walk into your practice, get on the cath table, get a right heart catheterization or an LVEDP of 35, and they're walking around feeling okay without any symptoms, congestion evidence. Keep that in mind that you can be compensated. That then leads to your right heart failure, and then the right heart failure is manifested by hepatic insufficiency, renal insufficiency, ascites, peripheral edema. And in the context of congestion, there's also decreased output that's in the center of it. So the symptoms signs assessment revolve around the fluid backing up and low perfusion in different percentage of impact. The problem that we run into is that, unfortunately, human beings don't predict like what we read in the textbooks. So as much as we learn this physiology, not all individuals present the same. These are the lists of symptoms and signs. People who are breathless and out of breath are probably the most obvious. But certain distinguishing features between heart failure and non-heart failure are really orthopnea and PND. If you're having paroxysmal nocturnal dyspnea and orthopnea, it's more likely it's heart failure than pulmonary symptoms. But if somebody has just exertional shortness of breath with complete asymptomatic being able to lay flat and no PND, it could be heart failure, but it could also be other reasons than heart failure, and you want to keep that in mind to investigate. Another key feature is a third heart sound. Auscultation, unfortunately, is becoming a dying skill, at least in the United States, but your bedside picking up of an S3, if there are any trainees in the room, I would enforce that you leave your training program by at least learning an S3 auscultation, because that's extremely important for heart failure. The less typical symptoms are probably the most important to remember because it's easy to miss them. The younger you are, the longer you have heart failure, the more atypical you present has been the dictum. I see a lot of young individuals, 18 years old, 25 years old with heart failure, who've gone around seeing GI specialists because they have more of GI symptoms. Total bilirubin is slightly high, AST, ALT is normal. So always keep in mind, younger individuals, longer chronic heart failure symptom duration, they adapt more, so their symptoms are different. There is a clinical criteria, the Framingham criteria, which culminates these probabilities into major and minor criteria. PND, as we talked about, neck vein distension, RALS, cardiomegaly, pulmonary edema, S3 gallop, hepatojugular reflex. These are all the major criteria. List of minor criteria. If you have two major criteria or one major and one minor criteria, the probability of heart failure is higher. I don't think in clinical practice we're using these criteria as much, but the concept stays the same of what we've talked about. Those are incorporated into here. A lot of discussion centers around defining the functional class. And everybody knows the NYHA functional class, A, B, C, D, 1, 2, 3, 4. I also want to remind you that if this functional class is as good as you elicit it. Unfortunately, in medicine, and especially these chronic diseases like heart failure, you really have to become Sherlock Holmes and sit there and interrogate your patients. If you ask a patient in your office saying, "How are you feeling?" they're going to say, "I'm fine." But then, if you probe, you'll realize that they've moved their living space from the first floor to the ground floor because they don't want to go up anymore because they're out of breath. So these are subtleties of eliciting the functional class and shortness of breath that I would encourage all of you to be more objective than just asking an open-ended questions. And it's extremely important to know if somebody's symptomatic or not. Another aspect of NYHA classification is NYHA class 3 being classified into 3A and 3B. HFSA, Heart Failure Society, has propagated this 3B definition, which not until recently got into the ACC guidelines. But there's a difference between somebody who's sitting and short of breath at NYHA 4 versus somebody who just gets out of bed and gets short of breath. The one who gets out of breath and short of breath technically is neither class 4 nor class 3, if you think about it. They're probably close to class 4. So that's where these class 3B symptoms come in. Most of the trials are slowly modifying the concept of 4 into calling 3B as ambulatory class 4. We're making it more confusing. But there is a spectrum for this. The bottom line is when you're treating patients, there's a spectrum for the symptoms, and it's important to remember that in that spectrum, people might accommodate and not tell you all their symptoms. The differential diagnosis is extremely important to keep in mind because shortness of breath, fatigue, tiredness, if you open up Harrison's textbook, you'll probably have like 100 reasons. Of course, we can't look at all 100 reasons every time, but patients are patients, not organs, and everything is connected. So you can have more than one reason for their symptoms, and probably complete distraction is your heart failure while they're suffering with other problems like pulmonary disease, obesity, sleep order disorder. So keep the differential diagnosis in mind. My only caveat is don't blame a differential diagnosis and walk away saying it's not your heart, go see somebody else. Because there's always a combination. It's easy to ignore symptoms and blame it on another disease process. Make sure you tie all those things up to come up with a diagnosis. In the algorithm that we talked about, essentially it's suspected heart failure that then leads to assessment with an echocardiogram. But a few pearls that I'd like to just throw out for reduced ejection fraction, your focus on diagnosis should be, if it's ischemic cardiomyopathy, I think it's much more well described. You go down the path of revascularization. If it is non-ischemic cardiomyopathy, you want to make sure you're not missing inflammation. Sarcoidosis, myocarditis, giant cell myocarditis. If it is load dependent, which is hypertensive heart disease, valvular or congenital disease, or is it genetic? Is it a family history? Is it metabolic? You want to make sure you pocket your thought process in these categories. If it's preserved ejection fraction, you have infiltrative cardiomyopathies. Amyloid has become a great deal of discussion in today's world because of some new therapies. You want to make sure it's not hypertrophic cardiomyopathy, which is genetic, familial, Fabry's disease, occult valve disease. We'll talk a little about it. HFpEF can be like HFpEF, but you make sure you're not missing aortic and mitral valves, which are very easy to miss. Hypertensive, and then comes the true heart failure, true diastolic heart failure. I'm going to skip these recommendations except to point out that cardiac MRI has becoming a good tool for diagnosis of cardiomyopathies, especially for scar burden, picking up a lot of inflammatory cardiomyopathies, along with MRI, cardiac FDG PET scan. I think we miss a lot more inflammation than we thought before. But these guidelines are available. And then I'm going to wrap up with one caveat that unexplained dyspnea is a fight between cardiologist and pulmonologist. If you have a patient who the cardiologist is pointing fingers to the pulmonologist and the pulmonologist is pointing fingers to the cardiologist, it's time to do an exercise right heart catheterization. Do an invasive test to prove whether it's heart failure or not, so that your patient's just not going in circle, struggling with, what do I do? No one wants to take the claim. With that, I'll stop and take any questions. Thank you.
Thank you for an excellent talk. Really, we have a couple of minutes for a couple of questions.
I have a question.
Please, Dr. Ahmed.
I mean, the medical community is shying away from physical examination nowadays, and they depend on biomarkers and imaging and so forth. How valuable is that, and how we can control this shift from physical examination, which is extremely important, I think, to the devices and imaging and biomarkers?
I think it's a very valid point that we're in the realm of technology, we are forgetting the limitations of technology. And I have a bunch of cases where I teach the residents showing if we just relied on imaging, we would have never diagnosed the patient because everything comes with limitations. And one of the reflex problems we're having is we're just ordering tests without knowing what we're looking for. So your physical exam, history, should then point towards why am I doing this test and what am I looking for to confirm it. And I think it's incumbent on all of us to make sure the future generations don't lose these skills, especially for diseases like heart failure, which is a syndrome. The history and physical becomes key.
We have time for one more question. If not, please.
Omar?
Thank you for the very nice presentation. In the fight between pulmonologists and cardiologists, I mean, you know, this is a long battle between those specialties. I mean, we short of breath, we see us there. Is there anything else other than exercise or podcast we can do? Things like BNP, for example, or other tools we can use to settle the issue between both teams?
That's a very good question. I think the question was between the fight between pulmonologist and cardiologist, apart from exercise, right heart cath, can we use other tests like BNP? I think you can use BNP, but you need to know the limitations of BNP, because the only place it was tested was in the BNP trial, which is in the ER when someone comes in shortness of breath. You can, and if it's negative predictive value is good, except that you also need to know the limitations that if the patient is obese, it could be falsely low. So to your point, the other tests I would recommend is exercise MVO2 testing, cardiopulmonary exercise testing, which also can distinguish between cardiac pathology versus pulmonary pathology. Unfortunately, a lot of patients can have both of them. So you're asking yourself the question, which is contributing more than just saying, oh, it's not this versus that.
Thank you, Dr.
Thank you.
Our next speaker